3 doctors and a person from an ambulance company. We'll have a 4th doctor arriving, I think, in a little bit. But tonight, we're going to be looking at emergency medicine. Just to reiterate what Paul mentioned, what we really are trying to do with this group is to bring together technologists and healthcare providers to learn, discuss, and network. A few of our past meetings have been on other related topics. We have on our meetup site some files from those meetings. If you want to go and look, it's under the More button, and then you click on that and you'll get to the files area. We have some plans for some future meetings. The one in March we're working on, possibly to be on electronic medical records, possibly one in May on aging population. Also talking to some people about the new updated HIPAA requirements that have a little more enforcement for business associates. And also the operating rules that just went into effect for eligibility and will be going into effect for electronic funds transfer for providers to get paid. We are looking, as Paul said, we are looking for volunteers to help identify additional topics and organize meetings. So our panel tonight includes Jonathan Feit, who's the co-founder and CEO of Beyond Lucid Technologies. He's got his MBA from Carnegie Mellon, which is my alma mater. And prior to Beyond Lucid, he had a career in journalism, and he also was an intern at the White House Office of Management and Budget. Dr. David Feldman is here. He's both a doctor and an MBA. He practices at Good Samaritan and El Camino hospitals. And he's also an angel investor and an advisor of startups. And he's going to be talking about his company, Interface ED. We're expecting Dr. Dorsetti to come. He's, I think, caught in traffic. I think he had to stay late on his shift. But he's both a doctor and a PhD from Stanford in decision risk analysis, machine learning, and clinical decision support. He teaches at Stanford. He practices with the Mills Peninsula Emergency Medical Associates. He consults with Sutter Health. He advises startups, and he has his own company that he's involved with. Dr. Doug Evans is also a doctor and a master's in public health, and he's the founder and CEO of Presidio Health, which is a revenue solution company for physicians and patients. He's also the CFO for a group practice of emergency physicians that covers 5 locations and includes 60 physicians. And last but not least, we have Anthony Norton, who's both a registered nurse and an EMT, emergency medical technician and paramedic. He's over 14 years of experience in emergency response in San Francisco, and he's also a member of the California Disaster Management Assistance Team. So I think you'll see we cover emergency response and emergency medicine from one end to the other with this panel. And so we're going to have a bit of presentations, a little timeline here that we're going to try and follow, and then plenty of time at the end for some panel discussion and your questions. So thank you for being here, and I think we're on track. So if I can ask Jonathan Feit to get started, see if we can bring up his presentation.
So thank you, David, by the way. So, and as far as being a doctor, I wish I was. I appreciate the upgrade, but these gentlemen to my right certainly make me feel unproductive. And Ram too, even though he's not here yet. Working even later, so there's that. So I do want to dovetail on something that David said, and appreciate very much the invitation, really to all of us to be here. On the one hand, emergency medical services is very much, and I think Anthony certainly can attest to this, sort of the unsung bit of the healthcare industry. They are at the front end of the spectrum, they are at the end of the spectrum. We certainly admire very much the fire, EMS, and other emergency response practitioners that we serve on a daily basis, but very much does not EMS generally does not get incorporated into a lot of the talk about healthcare technology today. So having a panel on EMS is a big deal on its own. What is particularly special about this panel that I hope you all will come away with by the end of all of us is this is the first panel. I've been in this industry about 4 years now. This is the first time I've ever seen EMS and hospital personnel talking on a panel at the same time, let alone the technologists that sit around them, being the practitioners, and help to connect and move the information between them. Generally, EMS and fire talk to themselves, and physicians talk to their own groups as well. There are some crossover, but it tends to sort of be incidental, not the focus, and that's a very big deal. Hopefully this will lead towards a lot more dialogue and more streamlined communication within the industries, let alone within the records. So with that, move on to you. I'm going to start by telling you a little bit about the space in which my company operates beyond Lucid Technologies, the why of which we're in business, so to speak, and then at the end I'll tell you a little bit about what we do. So as you can see just from the graphic here, really what we aim to do is connect the dots between emergency responders and the hospitals and care facilities they serve. Some of you, by show of hands, how many of you have heard of an accountable care organization? Great, so this is one of the big buzzwords of the times right now. What tends to go, again, not discussed in that whole topic is the fact that it's generally EMS or a function of an EMS provider of some kind to move patients among the different parts of the accountable care organization. So folks think about doctors and hospitals and pharmacists and nursing homes and rehab centers and whatnot, and their homes, and yet it is generally a medic or someone in a similar function that's moving that patient. So this idea of making sure that the provider in the field has the tools and technologies to be able to do their job safely, cost effectively, and efficiently. And with that, just a little bit about how we got into this business. I have a bit of a military background, training to be a medic in the U.S. Army, so I got a chance to see what field medics don't have in the way of technology today, even though folks talk about how advanced military technology is. My business partner, Chris Witt, who some among you may have met, actually experienced the death of half of his family following a car wreck in rural New Mexico. And he talks often about as often as it can be pried out of him to talk about such a story, the fact that the medics arriving on scene wanted to do a great job to save his father and his sister's lives, but didn't have any techniques at the time, and this was just 6 years ago, so there was certainly technology, not necessarily what we have now, although it's pretty similar now. They didn't have the technologies to be able to communicate with the care facility what they were seeing in the field. And so essentially they were a taxi, and being that they were in a rural environment, they didn't get there in time, and unfortunately, the rest is history. So our mission has very much been to connect those dots from the pre-hospital to the in-hospital. And with that, I want to talk to you a little bit about the imperative. This comes from just a little over, almost 2 years ago, the Director of Emergency Medical Services in Durham County, North Carolina. For those of you who don't know Durham County, it's the home of Duke Hospital, one of the most sophisticated hospitals in the world. And there, the EMS director spoke about the lack of what he called a perfect package that would essentially allow his medics to be medics, as opposed to being secretaries. The idea of doing paperwork and not focusing on patient care is not why people get into the EMS or medical industries. They don't get in to do paperwork, which sort of leads to a phrase that I say often, which is that there are definitely easier ways to make a buck than working in the EMS, fire, and other emergency service industries, but there are not many more fascinating ones. There really is a massive gap, as one of our advisors at the University of Pittsburgh Medical Center would say, between perception and reality of what emergency services is like today. I've had people suggest to me that when I call 911, there's a digital signal that goes all the way through to the city dispatch, onto the medic, back to my physician, and by the time EMS arrives on scene, they know who I am, what's wrong with me, where I am, where I need to go, and so on and so forth. I'm going to come back to this slide in a second. Unfortunately, this is more often in the United States what EMS response on scene looks like. What's going on? Let me get it documented down. Again, this one's from Alaska, this one's from Atlanta, and this one is from Pittsburgh, Pennsylvania, in the shadow of UPMC. I actually took these pictures. So the idea that, in fact, you have, in many cases, a digital system somewhere certainly the idea that there is technology in the ecosystem is real. But in the field, it's a piece of paper. And we talk about how we can improve the EMS industry in terms of its efficiency. It really comes down to three things. I'm going to jump back in a second. Again, I'm a little out of order here. But when you have a piece of paper and you have an average transit in the United States, including first aid, of 27 minutes following a 911 call, that can be in some place like San Francisco very short. You've got a lot of hospitals, you've got a high density of population. It can be in a rural environment like Montana or Texas or upstate New York, sometimes an hour or more in transit, and maybe by truck. Everybody thinks that it's, people often think, well, it's going to be by helicopter or by fixed wing aircraft. Not necessarily. You may literally be sitting, I actually sat behind right off the 5, not far from Yosemite. I sat behind an ambulance for more than 35 minutes on a 2-lane road in the middle of the night. Who knows what was going on with that patient while they were driving for more than 35 minutes to the nearest town to take that patient. So we look at how we can help with improving communication. We look at how we can translate that improved communication into reducing the losses associated with operating emergency services. And that's not just EMS, but again, it's fire, it's disaster response, it's accountable care. You have, and I can go into these offline or another instance, but the dynamics of how EMS and whatnot are compensated. People think it's very similar to doctors, that there's a CPT code or something like that and folks get reimbursed and so on and so forth. What they don't know, as you'll see shortly, is that the incoming president of the National EMS Management Association, a gentleman named Troy Hagan, who just moved from Idaho to Orange County, California, cited just about 4 months ago that $3 billion in emergency service interventions, these are tasks performed actually done in the field to take care of patients, go unbilled and uncollected each year. Show of hands, who thinks those don't get paid for? Well, they do. They get paid for by all of us. And this is why if you actually listen, for example, to the Obamacare debates at the Supreme Court, what many people didn't realize is just how central emergency services was to that conversation, around the idea that you can choose not to have health insurance. You can choose never to go to the doctor. But if your car wraps around a pole and you are unconscious and someone calls 911, Anthony or one of his cohorts will show up on scene, rescue you, take you to the hospital, and one of these fine doctors will take care of you. Someone has to pay for that. There is a law in the United States called EMTALA that essentially says if you show up at the hospital by ambulance, you get taken care of whether or not you pay for it. We pay for that. And so when I say we, I don't mean beyond Lucid Technologies, I mean the American public. And so the idea that if we can wrest costs out of the emergency service process, and by improving communication, reducing time and whatnot, we can do a lot to help improve the cost of care in this country, and certainly improve the quality of care. If you can take that 27 minutes, which is currently handed off, I'm going to skip back here, currently handed off in roughly 45 to 60 seconds. How many of you guys have seen ER or some other hospital show on television where someone's running alongside the patient telling the doctor what's wrong with the patient? Yeah, that part's pretty much real. Everything else on there is not really real, but the idea that you hand off that patient about 45 to 60 seconds is very real. How do you hand off 27 minutes of information in 45 to 60 seconds? It's impossible. And so what studies show is that on average about 46% of critical data is lost at the handoff from EMS to hospital. This is what got me into this business when I started looking at that from a military perspective. Military environment, it's pretty much the same thing. Anecdotally, that number can go up as high as 80%. Again, UPMC in Pittsburgh, we spoke with the teams of medics who essentially said we thought it was much, much higher. We pretty much ignore everything that comes in through the EMS providers because we don't know what we can trust and what we can't. What you end up with is a process that basically restarts when the medic arrives when the patient arrives in the emergency department. So you've got medics in the field who are doing all sorts of process to save this patient's life, documenting that, oftentimes on paper as you saw, then handing off the patient and the hospital starts again. Now you've got increased time to treatment, you've got redundancy in the process, you have a loss of potential critical information, and you've got delayed time to treatment. Basically, you've got a loss at every point along that chain. So when we got into this business, we knew that if we just talk about making care better, it's too fluffy. No one's really going to get it. We are running a business. Hospitals are businesses. Ambulance companies are businesses. Cities are businesses. At the end of the day, they have to pay their bills. And so we needed to ensure that what we were pegging our technology to were hard costs and hard revenues. The idea that if we could save time, money, and clinical care, that we can translate that into dollars. Well, it turned out those dollars were not that hard to find. Once you started looking into records that were published by city councils, for example, like in Mesa, Arizona, just outside Phoenix, you found that 2,200 hours of duplicate data entry, as you see, amounted to just 3.5 minutes per patient record on average. As these paper records were being brought into the hospital, scanned and or retyped, and if they were scanned, which by the way is what UCLA still does, in case you all want a perfect example of another high-tech hospital, they scan these records. And then so if you ask somebody in the hospital, are you using paper records? Well, we're not. We're using scanned records. And we took the admins who were previously typing up the paper records, and now we have them checking optical character recognition. For anyone based in Silicon Valley, you know that that's not a whole lot of time saved. Because just because you're moving the person around doesn't mean you're wresting costs out of the system. So our objective was if we could get this bottom line number down by removing the waste, we had a business. It turns out, as I mentioned, that number in aggregate is very, very high. In addition, here I'll give you a scenario of a medic, and Anthony, nod along if this has ever happened to you. You're doing a patient transport, you're documenting whatever you can in transport while, say, driving lights and sirens 50 miles an hour and needing to get that information written on a piece of tape on your leg with a Sharpie. That ever happen to you?
Yes.
Okay. What happens to all that information? What happens if there is blood involved and it gets on your fingers and it smudges the ink that you were just writing on this piece of paper, or you take a curve too sharply and you tear the piece of paper, or the patient is violent and they rip the paper out of your hands, and now this 27 minutes on average of transport information is now gone. Well, according to the Center for Medicare and Medicaid Services and others involved in paying for ambulance transport, if you didn't document it, you didn't do it. And this amounts to $3 billion a year. Here's another example. This is from a large fire department in California that actually is billing for services. Not all fire departments bill for services. There's a lot of misunderstanding around how EMS and fire are structured. I won't go into that here, except to say that there are some agencies bill, some agencies don't, some agencies are tax supported, some agencies are affiliated with hospitals, and there's a whole bunch of different ways. But here's one agency in California that does bill for services, and if I told you who it was, you would find it staggering, that they billed and collected just about half of what they billed for. The city ate the rest of it. And as you see, the EMS team associated with that fire department, even worse, they only collected about just over a third of what they billed for. So again, we talk about redundant processes, inefficient staffing. This is one that's particularly important to all of you in California, so go back and tell your congressman and so on and so forth. EMS agencies in California are hurting very much because there's a rule that essentially stemmed from the poor quality of documentation that was coming out of EMS runs. Essentially, they called it dumping, which is basically you take the patient to the hospital, you drop them off and sort of leave them there. And there was a quality issue. So the state put in rules through a variety of processes that basically said EMS can't leave the hospital until their documentation is done. The problem with that is what happens if another 911 call comes in. Someone needs to go get that other patient, which is why you end up having incredibly bloated EMS agencies in California that are struggling financially because they have lots and lots of duplicate staff. Basically, people who are working part-time. There's one agency in the San Francisco area that has roughly 700 part-time people working on staff, simply because they have to have backups for their backups in order to be able to go out and do the work. It's clearly liability in terms of being able to hand off those patients and have all that information. Again, who knows what and who did what, and we have a rhetorical question we often ask, which is, if a patient gets picked up by ambulance, stabilized, transported to the hospital, and dies on the hospital bed, who gets sued? Anybody? Everybody is the answer. So liability risk associated with data handoff is a critical problem. So with that, just going to give you a brief overview of sort of what we do. So I introduced this graphic that you're seeing, which is I put new in quotes because this is actually the way that emergency response and fire and whatnot have been working forever. People just didn't necessarily know it. I introduced this graphic at the Mobile Health Summit in DC a year ago, December, and started a little bit of noise for this around the idea that people sort of came to me and it suggested like I was talking about something new. Whereas in fact, as we were talking, some of the panelists and I were talking about earlier on, this is actually a fairly accurate demonstration of how EMS is supposed to work today. People think that happens when you call 911 and you again, you get picked up, someone arrives on scene, they transport you to the hospital does whatever magic they're going to do, and then they send you home. But statistics show that dramatically higher likelihood, if you're transported by ambulance, especially for assuming you're not a fraudulent case, which by the way represents 25% of all transports in the United States, if you are transported by ambulance for a high acuity case, like a heart attack, stroke, transplant, or some other condition, you are much, much likelier, over 60% likelihood to come back by ambulance. So the idea that you're going to be transported again is very high. But the information is not available. I mentioned I have a military background, so I take very seriously the following case, which is in San Francisco, which is both the seat of technology for the world and has a lot of military vets. If you pick up a veteran on Tuesday afternoon because he's having a seizure in the street, you transport him to the hospital, take care of him, stabilize him, and release him. He has another seizure in the street on Friday. Unless it's the same two-man team picking up the same person, they happen to remember him, there is currently no way to know that that patient was picked up for the same condition 3 days apart in California today. This is tragic to me. So again, when we look at the movement of information, wouldn't it be great if you could have that data flowing backwards so that the medic arriving on scene next has some idea of who this patient is? That's what our software is designed to do. We developed MEDIVIEW in 3 parts. One is designed to be where accidents most frequently happen that have emergency response units, for example, in an industrial environment like the Chevron refinery fire. The standard of standard operating procedure in an industrial emergency is pretty much the same now as it is anywhere else. In an emergency, you call 911, and then what? We asked this question. We've asked folks, so if you were to arrive on scene of, say, someone in this room hit the deck, although, well, you guys are here, so you sort of skew my example. But most places, if you tell them, so if someone in the room happened to have a heart attack, what would somebody do? They call 911. And then what? What happens until the medics get there? And they get this really scared look on their face, like, oh my God. I say, that's why you're getting sued, because nobody knows what's happening in between the time you called 911 and something happened. But when you look at industrial response, like refinery fires and mining disasters and whatnot, and construction issues, and in airplanes, the response is a piece of paper, and someone literally, I have pictures of flight attendants writing on other passengers' backs, and then they get down to the terminal and they write up what just happened. That happened in a Delta flight about a year and 2 months ago. The next link in the chain, MEDIVIEW Mobile, resides in the transport vehicle, so that the folks doing transport have a way of collecting all the information quickly and efficiently and easily using next generation technologies like GPS. We are the first in our industry to incorporate GPS that does not require an internet connection. This is mind-boggling when you think about what we can do if we want to find a restaurant. But we actually got a bunch of really weird press around, it was actually very good for us and very unfortunate from an instant perspective, around Hurricane Sandy, because our system does not need an internet connection. So we can continue working, whereas the vast majority of our competitors cannot when a hurricane knocks down the towers. Within 3 days of the Joplin, Missouri tornado that some among you may remember, Verizon Wireless came to our garage office in Concord, California, and asked how they could have used our system, because we can continue operating while they don't have their backup towers up. Yet our competitors, which are currently being used in most rural states, do not. The MEDIVIEW hub is designed to receive all that information in the hospital. So it allows the hospitals to access that information for free within 30 seconds of capture in the field, and we can provide that information to anyone tied to that patient, whether a physician, a nursing home, or even that patient's family. Just a quick quote that we got very excited about this one from my dear friend, Mr. Jenkins, sitting over here. A gentleman he used to work with who took a look at our system and described it on stage in advertising we could not have paid for, described us as a system for getting all the information that the hospital is going to need before the patient even gets there. That's what we're about. And another gentleman who is an expert in this field described it as, for example, a way of pre-registering patients before they even get there. This is a quote that we talk about again. When I find this very optimistic, that this is actually a letter we just received from a pre-hospital care directorate of a major hospital in the New York City area, talking about the role of enhanced communications, telemedicine, and telehealth in providing better access and sharing of clinical data. The fact that hospitals are starting to talk about this is not small. This is huge. And so I went over some of this already. I won't go too much into it, except for to say that our goal has been to be an all-in-one solution, making the information that needs to be available to the various stakeholders in a patient's care available to the practitioners who are going to be needing to receive that information on the other end. And the objectives are significant. The benefits are significant. Allow the patient to be intaken much faster. Get the information from the field into the hospital within 30 seconds. Activate triage teams. We hear so much. Some of you here may have seen the health IT bubble that is forming in the Bay Area. We hear so much about hospital operations and making them more efficient. And I will never forget, Scott, it was actually you or the gentleman that I said this to when we came to your Bay Area Breakfast Club meeting and said, so Dell, which Scott was working with at the time, had all of these solutions for making hospitals efficient and touching all of these different parts inside the hospital, from the computers to the data services, to the services that make them run. And we said, what's going on down here in the corner? And it was the ambulance. And there was nothing there. And within 2 weeks, Scott had gotten us not only technology, actually computers that we still use today. They're not even available anymore. We still use them. As well as dedicated teams to ensure that we got visibility within a company the size of Dell. We only have 8 people now. We had fewer then. And the idea that we got visibility inside a company like Dell is kudos to you. So thank you for that. I know you've heard me say it before, but now I get to say it publicly. It was a huge deal, and people are starting to talk about this. Improved care coordination, particularly around mass casualty events. Unfortunately, Hurricane Sandy made everybody aware of how bad this is today. I'm just about done. But we are starting to see very fast movement at places like the Department of Homeland Security, Health and Human Services, and others to finally close the gaps in terms of next generation care. You all will be hearing some of that in the coming months, I hope. Again, obviously from a business and usability perspective, we had to make sure that these technologies were easy to use. One of the biggest, we've gotten so much praise about our interfaces, which I find really happy, but we just designed them to look like a phone. It really wasn't rocket science. We figured everybody has a smartphone in their pocket, so let's make the system look like a smartphone. What we found is that when you go through bids that cities and counties and states are paying for, our competitors in this space have been charging sometimes up to 5 days of classroom training to utilize their systems. Oh my God, really? It's 2013. I mean, the idea that you couldn't use online training and design your interfaces well was a remarkable thing for us to hear that hadn't been done. So we put a lot of focus into that, but the idea of making it easy and even fun for folks to use the systems in the field was an imperative that we took to heart, and we've actually been happy to find that others are starting to follow with next generation technologies like voice to text and things that, again, are being used so many other places but have yet to make their way into EMS. I won't go too much into this, but just a glimpse of what could happen here for any of you here interested in big data. So again, another bubble starting to show up, or maybe finally starting to hash itself out. But the opportunities here are significant, and with this, we talked a little bit from Presidio Health, for example, and your opportunity to make the data from the pre-hospital environment useful. This is really the end game for us. Is you've got these caches of data that are going onto paper records and filling out bubbles and bad handwriting and all this stuff. And if you can use a positive experience and an easy interface to get all that pre-hospital data where it needs to go at the speed that data works in every other way today, you can use that to build smarter cities, quite literally. We've talked to some very large companies like IBM, which talks about smarter cities, about being a data source for them, because they're currently not getting anything from the EMS environment. The data literally gets locked inside the ambulance world and it never moves anywhere. And the idea that we can move that data and hospitals can use it to be more efficient, cities can use it to figure out where they're going to send patients when they shut down emergency departments, or where to build a new one. And certainly there are other opportunities across the healthcare market, from the military down to the private physician. So that's our presentation. Thank you very much. Of course, I'd be happy to answer any questions later or show you guys a demo if you'd like. Thank you.
My name's David Feldman. I'm an emergency physician and also involved with Interface ED Solutions, which is a startup company that we're focused on the usability aspects of EHRs and sort of what that means in terms of patient care. So like Jonathan was saying, and talked to everybody on the panel, I'm really excited about tonight because I agree with Jonathan. I think that this is a long overdue opportunity for us across the spectrum, from the EMS, the responders, first responders in the field, all the way through the hospitals into some of the work that does after the patient care to improve and work on areas that I'm passionate about, namely health IT, information technology and information flow, and then also the usability of aspects of EHRs and how they impact patient care. And that's sort of what got me excited about this panel. And so for that, I thank you for putting this together, David, and I'm looking forward to a good conversation tonight. So what do I do? Primarily, I'm actually an emergency room physician. That's what I really enjoy doing, and that's what I do on most of my days. I work in a busy emergency department. I work at Good Samaritan Hospital. We see about 45,000 patients a year. We're a cardiac center of excellence, and we're a stroke center of excellence. So we see a lot of acute STEMIs, we see a lot of acute strokes. We take care of patients every day who are critically ill. And I like it, I enjoy it. I feel it's, not to sound trite, but it really is an honor to take care of these people in these critical moments of their lives. And in general, we have a really good practice. We have less of a really good practice now, because one of the things that David asked me about today to speak about was what's been my physician experience with EMRs. And for the most part, we have had to deal with mandates from CMS and from the federal government to use EMRs. We had an EMR implemented at our hospital about 4 years ago. And to kind of paint a picture of what sort of my day looks like, I run around the emergency department, I see about 20 patients a day. An 8-hour shift, 20-25 patients, and it's pretty busy. In the past, I would dictate my notes, and the note serves to a number of functions. One is primarily a communication tool and a way to create a medical record that's usable, and then now the government wants us to create data so that they can start to look at it and analyze it and control costs. So when we got the EMR, typically when I did my note, it would be a dictation. Dictations take about 4 or 5 minutes. When we got the EMR and we started putting it in place, and actually I was the physician who led the implementation for the EMR, and we found that our experience initially was 15 to 20 minutes per patient chart. So now you're talking about additional 10, 15 minutes per patient, 20 to 25 patients a day. You can imagine it's 2 to 3 hours additional work that's put on us for a system that we did not ask for. So show of hands, who in the room would be excited about a new software solution that is going to decrease their productivity by 30%, i.e. you're taking about a 30% pay cut in terms of what you're making on a daily basis? Yeah? So not too many hands in the room. Okay. So we have had a pretty standard industry experience that we've not enjoyed our EHR. And that's kind of been industry norms. If you look across the industry, in the short term, most ER groups take about a 40 to 50% productivity hit. Then they do some things to try to make it better. They do some things where they don't even then have to interact with the EHR at all. They hire scribes. So you may build a beautiful system that actually can make me a better physician, and I may never actually use or see that system because I'm going to hire an electronic caddy at 10 or 12 bucks an hour to deal with the computer, and I'm going to go back to doing what I like to do. Again, another cost hit, another cost shift. So there are many stories like this, and there's a palpable frustration in the provider community because the stakeholders, the physicians, are using these systems that aren't designed well to utilize. And what does that mean other than my coming up here tonight and asking you at the end of a long day to complain and whine about I don't like using a computer system? I don't think most Americans in this country are going to feel too bad for me as a physician that I'd have to use a computer software solution. Oh, you got to stay late at work. So is there another way we can measure kind of what that means and what the opportunity might be potentially for someone who can address this issue? So if you could design a system that's better than the systems now, instead of taking 10, 15, 20 minutes per patient interaction, and you could save people 2, 5, 10 minutes per interaction, what would that mean in terms of dollar amount? What kind of a business opportunity would that be? And if you look at the data across the country, about 124 million emergency department visits a year. And if you save a physician 10 minutes and a nurse 10 minutes, what does that mean in terms of their cost per hour? And you do the same thing across outpatient visits, almost $1 billion a year, and then inpatient admissions plus consults. You quickly realize that you're talking about $18 billion in opportunity, where we're actually creating systems and mandating systems that make the provider frustrated take them away from direct patient care, which is where we want them. We want them at the bedside taking care of patients. And then in the end, distracting them from taking care of patients, which is when we're sick and we come to the emergency room or we get admitted to the hospital, I don't want my physician, this is obvious, physician at the computer, I want them taking care of me. So this number, it's a big number, $18 billion. But this might actually even further undervalue what we're talking about here, because if you can actually create a system that saves people time, but then helps them make better decisions, helps them avoid unnecessary tests, unnecessary admissions, you're now talking about making a dent in the 20 to 30% estimated waste in the $2.5 trillion healthcare industry that we're all struggling to pay for, right? And like Jonathan's point is excellent. Somebody always pays for the care, regardless of whether the person who's receiving the care pays for it. So I think it's a problem worth looking at. The bridge between the way technology is developed and the way that the stakeholders utilize and benefit or don't utilize and then detract from the direct patient care that they get. So going back to my experience and the second piece that David asked me to talk about, which is interface ED solutions. So I work at Good Samaritan. I was talking to a colleague of mine who happens to be in the room. And this colleague is an emergency physician and also has a PhD in physician decision making. And in the course of a conversation of dealing with this information system that we both didn't care for too much and felt like it slowed us down, he started explaining to me a system that he envisioned that actually could mirror the cognitive process of a physician, that could actually help you come to a diagnosis, but more importantly sometimes help you satisfy a differential diagnosis that you need to exclude, and do all of that within a minute. So imagine a system that you could have complete a note within a minute, but not just complete a note in a way that augments the physician's decision-making process, that is nimble and moves with them, that is diagnosis-based because that's the way physicians really think, then you might have something. So I have an MBA. We decided we were going to put together a team and try to build that system. So over the last 3 years, we've built that system. And that system is interface ED. And it is not an EHR. So we actually benefit from not being a complete system, but being an agnostic software program that sits on any EHR. If you can type into EHR, we can drop it in. And then if these companies start to realize that we're actually being successful, they may start to work with us, and then we can get access and we can actually go into their parsable databases and drop into the exact fields they want, and then start to satisfy meaningful use criteria. So we've designed the system. I use the system every day. My partner uses the system every day. It saves us time. And we feel that we are onto something that actually will make a difference in the care of the patients that we deliver. So not only does it save us time, but by creating a system that allows you to generate a note within a minute, it saves the providers, the end users, time every day. So they're going to start using the system. They're going to like it. Because guess what? They're going to go home on time. And then you're going to start to build certain efficiencies in your department. And they're going to let them use the system and let them take care of patients and not have to be chained to a computer screen and dealing with a clunky system that they don't like. On top of that, we've designed a system that allows you to deliver the latest and the literature-supported recommendations for clinical decision-making at the point of care. And that actually is also something that we, in the process of developing this, have kind of worked our way into. And what that can do is that can then affect behavior. And if you can affect behavior because you're using a system that they like and become essentially integral to their workflow, you can start affecting the most, what we talked about earlier, the most expensive piece of healthcare equipment out there is the physician pen, because then you start decreasing ordering on unnecessary testing. And I'm not ordering a CAT scan on a 2-year-old child because I think it's the right thing to do. But I can actually look at the system and it gives me the algorithm for what's recommended. It doesn't make the decision for the physician, a big difference, but it gives them right at the point of care, the information they need to make their decision based on their risk tolerance, their practice styles, and the community that they serve. At their institutional standard of care, what resources they have and how they can best execute care for that patient at that time. So that's pretty much it in terms of the two short things that David wanted me to address. And so I'm really looking forward to tonight's panel. Thank you for your time, and we'll continue the conversation.
Hi, I'm Doug Evans. I am also another physician. I work up in San Francisco at one of the main hospitals in the city. And also, as David mentioned earlier, I manage a physician group across now 5 hospitals in several counties and more than 100,000 visits per year And so during that time, I've understood how physicians actually work, and they're just like you and me. You give them a tool, it can be a good tool, it can be a bad tool. They may use it differently, right? Some people can figure out computers and how to use email. Other people can't figure out how to use the TV clicker. So the approach that Presidio Health takes is managing physicians' performance for quality. And in today's environment in ACOs, healthy systems, healthy hospitals. So there's a big gap between what happens at the point of care and what both Jonathan and David described in terms of pre-hospital care and ER care in terms of the care that's provided, and then this holy grail, what we all consider to be quality, right? So we want good outcomes, we want the best care, but there's a lot of things that happen, and there's a lot of roadblocks and speed bumps between the time the care is provided and this measurement by other bodies, hospital, health systems, CMS, ACOs in the future, in terms of what is quality. And then the question becomes, how do you reimburse for that quality? So there's a huge transition towards that, away from billing for services, billing for procedures that you do, towards this concept of paying for quality. So in this environment, care does not implicitly mean quality. The doctor has to provide the care first and has to do it according to best practices, and then has to translate that care into the electronic record. So we've heard both instances of the pre-hospital care going into an electronic record, and then David's interfaced ED solution making that easier, but the translation is not perfect. So we're looking at problem one, which is getting data into an electronic record in order to serve this ultimate measurement of quality. And there's problems with that, right? User problems, tool problems. The largest EMR out there in the country, if you're not all from healthcare, is made by a company in Madison. It's a private company called Epic. It's the biggest system. For the ER, it's probably in the middle of the road in terms of bad systems. And one of the CEO of UCSF said it's the best of the worst. It's the best we got, and we're using it, not because we want to, but we have to. So, I applaud David's efforts to make that whole process easier, because we're all working with tools that take a lot of time and don't get the quality data into the system. The next step is getting the data back out of the systems. And that same reference EMR, Epic, has a huge network system, but they have the worst reporting tools in the industry. So again, we're trying to get to this quality measurement, but we're being stopped along the way in terms of getting those high quality measures actually to that goal. Then there's this process of coding. So it's that data extraction for the purposes of today's world, so billing by procedure, but coding will be data abstraction as well in the future for what did you do, how well did you do it, did you meet our benchmark quality measures. And then the final piece is getting data out for reporting. So getting information back to the providers. How well did you do? Did you meet the benchmarks and expectations in this aligned world where we're all incentivized to provide quality and we're paid that way? Did you get there? And so that's what Presidio Health works on. And the issues really come about from these 3 points of inflection between the actual care and this measurement of quality. So the first piece is clinical care. Out there today, if you look at an ER with 20 doctors, they'll have 20 different ways to put in information. There isn't standardized methods. Everyone's going to have their own workaround. There are shortcuts, and everyone makes their own shortcuts, but they don't follow standard. They don't follow standard for the ultimate coding of that document, they don't follow standards for medical legal, they don't follow any standards for measuring or looking at quality. So the first step that we are working on is normalizing and standardizing that process. So how do you educate your physicians? How do you train them? How do you bring them on board when they're new in order to standardize the process of data in? And it's a challenging task, but the alternative is to take whatever they put. And again, David's system is a big step in that direction in terms of making it easier and putting in tools in place so that physicians can work from a standard template, and there's decision support behind that to say, yes, you're doing the right thing, here's the considerations, yes, you're taking the right path, we're going to optimize your steps towards documenting that quality record. And as Jonathan said, if it isn't documented, it didn't happen. So next step is getting the data out and tracking. So on a regular basis, at the end of my shift, I want to know how well I'm doing. If I'm being paid at the end of the month by my hospital that's part of an ACO, that's being paid by that ACO according to the documents I produce, I need to know how well I'm doing on a regular basis. So the process of extracting data out of that EMR, standardizing it, and then putting in front of me my list of where I need more work, what I forgot to put in, despite all the best tools, so that at the end of the day, I'm hitting 100% of my quality measures. The final step is putting in an intelligent coding process. So we use natural language processing to pull data out of the records, and we populate that in front of the coding professionals who actually extract the data for the final records that go to billing or the quality measures. From that process, we also create dashboards for the physicians and the providers, so nurses and physicians who work in that service line, in this case the ER, in terms of how well you're doing it on a regular basis. And we're not just looking at quality in terms of coding and the typical things you would think about in terms of, did I give the aspirin for the chest pain that came in? Did I order and interpret the EKG for the STEMI heart attack that came in? But other things like, am I providing good patient care? There are all kinds of reports about patient satisfaction. Am I providing good care to my patients, and do they appreciate the care in the surveys? Am I providing efficient care? So am I getting the patient in and getting them out quickly so that they're not spending half their day in the ER? Am I providing compliant care in terms of safety and quality? So in the end, it ends up being billed somewhere, right? There's someone being paid for this, but the purpose of all this is to connect the actual care event to 100% quality measurement for the purposes of moving the industry forward and actually providing better quality care for patients. So you can see there's a number of considerations that overlap between what Jonathan provided in terms of his presentation and the EMS system moving into the ED with data. And some of the implications for what we do has a lot of overlap. So the ER can work with the EMS agencies to make sure, yes, did you provide good care? Was the handoff good? Are we all aligned towards getting to this quality goal, starting before the hospital, all the way through the EMR production, all the way through to the patient being admitted or discharged home? So I'm intending this to be, to some degree, a source for discussions around the panel in terms of any interest you might have in this larger system, where the industry is going with ACOs and data and big data in the next 10 years. So thank you.
I'm a paramedic. I'm a nurse, just became a nurse. But I've been doing the paramedic life and the emergency medical technician life for many years. I got certified as an EMT in 1981. So been doing it a little while. They kind of consider me the dinosaur of the field. fact, me and my partner, Daryl, we've been together for 6 years, which is unusual for an ambulance crew. And he's got 25 years experience. So between the two of us, we got war stories. A few things, you know, this is, to me, it's an honor being on this panel, being in the field, as they say. I've seen lots and lots of changes in EMS and emergency medical services and pre-hospital care in the last, you know, almost 30 years that I've been playing in the field. Up until about 2.5 years ago, we were on doing paper for patient care reports. And I was really good at doing a really fast patient care report. But then they you know, the company came out and said, okay, we need some insurance information. So that was a whole nother form that took extra time. Then they came out and they said, we need to collect data. So they gave us these horrendous bubble forms. So what went from about 10 to 15 minutes after a call turned into 15 to 20 minutes after a call where we had to do paperwork. So, you know, this slide just basically shows my life on a call from the injury or to the sickness of this patient had. So times are made up, the address is made up, and I had to put the patient's name on her to protect her for the HIPAA violations and stuff. So we'll just call it 5:15. Our patient, little 75-year-old woman, she was a architect out in front of a property she was looking at managing. And she had a sudden onset of, yeah, I'm kind of feeling a little faint. You know, I don't feel very good. She didn't completely pass out. She didn't fall down or anything. So her coworker basically got a bottle of water and didn't give it to her drink, just poured it all over her. So she was soaking wet. You know, they thought it was a hot flash maybe that she was having. So then they called 911. So at 17:22, 5:22, we get dispatched with an engine. So in San Francisco, for any code 3 call, they're required to send a fire engine and an ambulance. And San Francisco is different because some of the engines don't have any paramedics on board, and every ambulance has to have at least one paramedic. But for every code 3 call, you have to have 2 paramedics. So if there's a fire engine that has no paramedics, they're going to send 2 engines, one with a paramedic, even though they're coming from farther away. That's how we work in San Francisco. So we get there, we pass by engine 12 station because it's right around the corner from UCSF, and it's actually on the same street where this call was. And we see this is a lady that we can handle, so I get on the radio and say, you know, you can cancel the engine so and they don't even have to get out the station. And our partner gets the gurney out, get her on the gurney, lift her in the ambulance, and we're sitting there talking, you know, hey, how you doing? What's your name? What's going on? You know, why are you soaking wet? So I managed to dry her off a little bit, and my, you know, I like to teach my interns, you know, the people that I'm training, I like to talk and do at the same time. So I'm sitting there talking to her, and I'm putting the EKG leads on her, you know, and I have an electronic blood pressure cuff. I'm putting that on her. So, you know, I get her vital signs, which, you know, so now we're at 5:28. So, you know, remember the initial call came in at 17:22. So about 6 minutes in, I'm getting the vital signs. Then I get her on the 12 lead. This kind of shows a picture of what a 12 lead looks like. And let me see if I can bring up the other one. So that's kind of a bigger one. So this is not her exact EKG, but it shows an acute heart attack, acute MI suspected. So that's what it looked like. Okay, and I looked, and she had elevated T segments. That's pretty bad. This is, you know, it's a STEMI. That's what we call it. That's, you know, that's one of the things that we like to get to the hospital, do pre-notification of the hospital, and soon we'll be able to transmit this to the emergency room. We're not able to do that yet in San Francisco, but that's one of the things that we're working on being able to do. Let's see, how do I go back?
Up arrow.
Up arrow. Okay, so I've got the 12 lead. So then, you know, when I look at that 12 lead, it says acute MI suspected. You know, my face kind of goes into shock, and you know, she's 100% with it. She says, "I'm dying, aren't I?" I said, "No, you're not dying, but you're having a major heart attack." So we were actually about 3 blocks away from the hospital. I get the IV started, get her on some oxygen, and we, you know, transport lights and sirens code 3 to UC. In the meantime, I have to call up the hospital, tell them we're coming in with a STEMI alert. This patient's having a heart attack. Get her to the hospital at 17:35. She's at 17:36. You know, get her over to the ER bed. 10 minutes later, she's in the cath lab. That's fast. That's really fast from, you know, it's 24 minutes from dispatch to the cath lab. There's a lot of calls that are a lot slower than that. Okay, there's actually calls that might have a little bit of time to be able to download some information and send over to the hospital. This is a time that we had no time to. I barely even know her name, walking into the emergency room. So that just kind of gives you a little idea of what it's like to put on the uniform and run a call. I'm excited about, you know, being able to get information to the hospitals before we walk in the door. That's huge, because we have to stop a lot of times, especially on a critical patient. We have to stop at triage. Okay, what's the name, birthday, and everything else, where that could have already be done, and go straight to the treatment rooms. So this would actually save time, so I'm really excited about that. So again, thank you guys. If you have any questions, I'll be glad to answer them on the panel.
My name is Rob Durisetti. I'm an ER physician. My PhD is on the statistical computing side. That's kind of why I got involved here, I guess. I don't know, because there's plenty of ER docs here. But I think sort of my take on a lot of this is, I think it's fantastic that there are lots of people trying to solve all sorts of different problems within the healthcare field. I don't think one should view the fact that someone isn't offering a silo solution as fragmented approach to the problem, because I think different people bring different approaches, and that has value, and I think everyone who lives in the Valley knows that. I think the challenge is integrating that data, and people throw around the word big data for lots of different things. I think for medicine it's particularly valuable for a couple of reasons that I'll elaborate on in just a moment. I think one of the biggest problems in any of these discussions, whether it's on the national level or in a small room with a small gathering, is the use of terms that we can all agree upon what their English definition is, but the actual hard engineering application or the statistical application of that term is not well defined, and that is the term quality. So what is quality in medicine? So I think it's, when people talk about best practices, best standards, it's important and maybe distressing for the layperson to understand that a good percentage, less than 10% of what we do in medicine is backed by any good evidence whatsoever. Much of it is based upon personal preference, much of it is based upon tradition, much of it is based upon a poor access to knowledge or poor upkeep on their own education. And this affects fields from cardiology on down to things where the patients tend to be quite healthy, as in obstetrics and gynecology. And I mention those two in particular because about 15, 20 years ago, JAMA came out with a publication whose conclusions made themselves be suspect, that the two medical specialties least supported by the actual evidence in terms of their interventions they perform are cardiology and OBGYN. And I think that's interesting because you have to look at the populations you're dealing with. In one, you have a relatively sick population, and the other, you have a relatively healthy population where keeping your hands off probably does more good than bad. And you have pretty large populations in both sets. Data is not well captured in medicine. There are interface issues that people have talked about. But even when data is captured, the challenge in medicine is not just, it's the fact that, I don't know how many of you deal with graph theory, but it's a highly connected graph. When you're dealing with symptoms and diseases, it's a highly connected graph Lots of symptoms map to the same disease, lots of diseases map to the same symptoms. And whenever you deal with a highly connected graph and you're trying to run any sort of computational algorithm on it, it's by definition NP-hard. And there are lots of people who are from engineering background know exactly what I mean about this. And it is an NP-hard problem. And the problem with NP-hard problems is that, especially in these data populations, you talk about big data, is that data fragmentation becomes a big problem. If I have a data set of about 8,000 patients, and let's say I create a completely simple problem, and I say there are binary realizations on 4 different random variables, right? So I have about 16 possibilities, and I have 8,000 patients, and I've created a super simple situation. I've already fragmented that data set into 500 cohorts, right? 500 patients per cohort. But if we're dealing with data sets of 8,000 patients, how often do we run into that on medical situations? We're incredibly fortunate we find a study with more than 500, 400 patients, and with many more random variables than 4, and many more realizations on each of these variables than a binary realization. So what ends up happening is many of the conclusions that we reach are, quite frankly, suspect to both alpha and beta errors. They're just suspect conclusions. Eggs are good for you, eggs are bad for you. Salt is good for you, salt is bad for you. HDL cholesterol is good, no, HDL cholesterol is neutral. Cholesterol loses its patent, now HDL cholesterol isn't really that important anymore. So there's all sorts of stuff out there that's really difficult for people in the lay population to really parse out. And from the engineering standpoint, I think physicians need to be really good engineers, but they're not. They're just not. They sometimes don't like to think precisely. And I think one of the things Doug's talking about that I think is important when you're dealing with managing a group, also because I do practice clinical emergency, I'm not just spouting, I actually practice emergency medicine still. I just came from a shift actually, which is why I was late. But it's challenging, it's hurting cats to some degree, but it's also easy for people to challenge you for exactly the reasons I said. When people say, well, you know, this seems to be a better way to approach things, and the answer, of course, is why? What evidence do you have to support that? I've been doing this for 10 years, and my outcomes are no different than yours. And this is actually a really important realization when we're talking about big data. When people have looked at physician and cost savings and efficient use of resources, when you see the disparity between utilization that occurs between physicians, and it's huge, even in something like an emergency department, you don't see that translate into any sort of disparity in outcomes in any reliable way. So whenever you see that something like this, you know there's an opportunity for improvement. And I think the challenge is bringing systems to bear that capture the data in an effective way, but then people who apply the proper computational constructs to that data to actually get something useful and make a reliable conclusion without necessarily having a double-blind, placebo-controlled, randomized trial.
Okay, well, thanks for going over that. I think we're going to move into sort of a panel discussion and kind of come back around. I think I'm going to try to seed the discussion with a couple of questions. I found a news article today that there's an agency called CLASS, I don't know if you'd call it an agency, a study group, that came out with a report today that talked about best of breed emergency department information systems. So I'd like to ask some of the doctors to comment on their thoughts about emergency department information systems. We already heard a bit of a comment from David about how some of these large electronic medical record systems that were designed for use in the hospital are somewhat difficult for a lot of physicians to use. Maybe that's putting it kindly. I know when I was in to see my doctor just the other day, he turned the screen towards me and he said, there's 2 levels of menu up here and 3 navigation bars off to the left, and then I have this little area down here to write my note. It was a very cluttered screen, so I think I understand what you mean. But I'd like you to maybe comment on the applicability of tailored emergency department information systems. Do you think you're seeing some emerge now that are better suited for your purposes?
I've got the mic, so I'll answer first. the EMR industry is definitely in its version 1 state today. There's the first generation, they're clunky, they're not very user-friendly. So to answer your question about the class survey is, if everyone in this room seen U.S. News report about best colleges in the United States? Or you've seen those little centerfolds around best doctors in any given city, and you wonder, like, how do you get to be a best doctor in that report? Like, who knows who that person is? And then the university is like the best of this. Like, well, what went into them being the best? The same thing applies with EMRs. You know, there's lots of considerations that go into it. They're large systems that work across an entire hospital. So you can imagine of the 50 different units and users and different disciplines and types that need to interact with this EMR, that it's impossible to be the best across the board, but particularly for emergency medicine. And in this case, and it's, you know, it's one unit in the hospital, but it's a very important unit in terms of efficiency. EMRs are bought by the IT groups that serve the needs of the hospital for IT systems, right? So ease of use, ease of management, and for billing. And then any unit in the hospital that may not be the best, you get what you get. So that's why David's doing what he's doing, because the epics out there are awful, and they don't work for doctors. So class, it's kind of hard to interpret class for me because they're all pretty bad. So it's the best of the worst in most cases. So that's my view.
Anyone to add?
No, I would largely agree with Doug. I think that it is very much a first generation. I think that what I've observed working on what we're working on is that this is not unique to the healthcare experience. There are cottage industries across many different types of environments where the bridge between the IT development and then the end user is a chasm. And then you have these players who then scoot in and actually start to work with the users and develop. And then a lot of large systems do it in-house or post-initial production and then try to improve. So it's actually not an uncommon thing. I think the paradigm that Doug alluded to is that the hospital systems, the purchasers of these systems, the shareholders per se, are not the stakeholders, are not the physicians and the patients that ultimately use the system and then depend upon that interaction for their care. So I think I would agree largely with your comments. And someone's going to solve this issue. Potentially, Interface CD is going to be a major stake in that, but it's going to get solved. I think the only other comment is just, you know, we are using people now as a technology to bridge that gap. And the scribes that I mentioned, that basically is the current technology that is out there that is widely successful. And eventually that'll be replaced by something IT, and hopefully that'll come to pass sooner rather than later.
But I'll just add one thing, but with respect to the pre-hospital environment, because it's a question we deal with as well. Just to start off with a little bit of a story, you mentioned my background as a media type before I was in this industry. I actually introduced the world's first all-digital magazine a couple years ago. And we had a phrase when we did that, which we became the first to change font sizes, for example, to be read on an e-reader that wasn't just a digital copy of a paper magazine. We were the first to embed video alongside an interview, alongside a text interview, because we could. So we came up with a phrase called "respect the medium," and it was just that simple, which was the idea that, you know, if you take something that's a broadsheet piece of paper and simply shrink it, you're going to make it a pain. But if you realize that you have a different form factor, so to speak, and using design concepts, I mean, we're obviously in Apple's backyard here, so you can speak that way. But respecting the medium, you can do a lot with that. And so one thing that we found in the emergency service documentation side of things is medics tend to get really offended when you basically say, well, you know, you're a medic, therefore you're a medic, and no matter where you are, it's the same thing. Well, on some level, EMS is EMS is EMS. I mean, you're trained in a very similar way across the country because there's a baseline standard of care. But we realized very early on that there is a vast difference in providing emergency care in a blizzard as in a tornado, and in a mountainous region as in the middle of San Francisco is a mountainous region, but besides that, if you're in a flat city versus up in the hills. And by developing technologies that could be flexible, and respect that medium, it became something that we found a lot of people really resonated with, or resonated with a lot of people, rather than assuming one size fits all. And I think it sort of goes to your point about this idea that you build a big clunky system that does everything for everybody, and it ends up doing nothing for nobody. But rather, if you realize that allowing, especially given new technology, that systems can be tweaked and customized, and things can be moved around on a screen, or you adopt, in our case, for example, a model of a phone, something that people are really familiar with, and start from there. People have a certain comfort there, and then you can adjust according to actual workflow. I think one example of a company I recently spoke with about this was IDEO. I'm sure many people in this room know IDEO, and they were, they sort of pioneered the anthropological model of doing design by watching people do work as opposed to assuming you know anything. And what ends up, I found really interesting, I did 2 cross-country trips in a year, the shortest of which was 5 weeks, the longest was about 2 months, and my wife was not happy. But what we found was when you actually sat and talked with people in the field, they were willing to give you a lot of information. And if you never went to see them, you'd never know what was different between what you thought actually was happening and what it turned out were the pain points.
Let me move on to another question then. If you want to jump in from the audience, we're at about the 8:20 point, so we're not under a lot of time pressure. We're doing good. I have one more that I wanted to ask about, and that is about health information exchange. I wondered if some of the doctors could talk a little bit about your experience, and it was alluded to in some of the discussions here, about seeing a patient who was seen 3 days before, seeing a patient who actually has a chronic illness, but how easy or hard is it to get some background on them, or are you starting from scratch every time in the emergency room? In your hospitals where you're working, do you have ways today to get at some of that, or are we still waiting for that system to be available in an urban area where if someone is being seen on a regular basis for a chronic condition, but then they show up in an emergency room, that somebody's going to know about them? Can you comment a little bit on where we are with that, please?
Can Tony provide the EMS version too?
I think, probably the singular failure of the government in this particular role has been providing standards. They spent a lot of time talking about how doctors should work, how healthcare providers should work, defining metrics for quality that are frankly meaningless, and don't actually measure any notion of quality. And yet, they've never given you a standard. They've never given us a standard. As an engineer, if I told you, everyone just use whatever date format you want, we'll figure it out in the end. How would your systems operate? What is the difference between browsers 10 years ago and browsers now? Can you imagine implementing the websites we see now in browsers 10 years ago? There was no standard, right? And so even now it's problematic, and this is not a building in which to have this conversation. But the point of the matter is that this has been the failure of our government. This is their job. This is their job. And they have not done this. And whether that's because they're ignorant, whether that's because they're incompetent, or whether that's been because they've been influenced unduly by industry leaders, Epic, McKesson, Cerner, who have had more of a say in this process than they probably should. I don't know. But I do know that if you talk to Judith Faulkner, and I don't know how many of you know who she is, but she's the CEO of Epic, she's the original founder, she'll say, people play fine in our Epic garden. That's the term. I don't want to play fine in the Epic garden. I don't want to play fine with the set of hospitals that can afford your expensive IT system that is expensive to install, expensive to maintain, and gets useless updates at a huge cost every couple of years. I don't want to do that. I don't want to play in your IT system where if I'm with Palo Alto Medical Foundation, they have Epic, and I'm with Stanford University, which has Epic, I need to build a cross map to actually get your data. What kind of Epic garden is that? Right? And she might tell me it works fine. I would tell her, well, in the last 5 years, I'm pretty certain I've seen more patients than you have using this system, roughly 25,000, and I've put more orders in patients in this system than you have, roughly 250,000. I know what the deficiencies are relative to you, much more so than you do, likely. So the issue is that there's this interoperability issue that even has to be addressed before HIEs even become a topic of discussion. And within the HIE sphere, we can always talk about, you know, we let the perfect get in the way of the good. And in this particular context, I'm referring to privacy. The vast majority of people in this room don't really give a damn if the other person knows particulars about their medical care. In fact, they would prefer that they know those things. A small percentage do. And a small percentage do for legitimate reasons. Probably an even larger percentage of that probably for reasons that are not things that you and I would support at a societal level. And every ER doc in this room is smiling about that because they know exactly what I mean when I say that. And with respect to the version 1 thing, I actually disagree. I actually don't think these systems are in version 1. I have no idea what version they're in. They're out there doing whatever the hell they're doing. These systems have been around since the 70s, whether they're in a DOS format and now evolving into a UI, whether they're now implemented on Citrix Server, or now whether they're cloud implementations. These systems have evolved. They're just evolving in a nebulous way with no direction. So ultimately, yeah, we'll get to something good, I suppose, but this is not how we want to move forward.
I think just an editorial note and some reading that I was just doing, I think it relates to there's nobody in charge. And this was pointed out in an article I think was actually published around 2007 or 2008 about complex adaptive systems. And it's the idea that our whole healthcare system is complex adaptive system instead of a monolithic system. So without someone being in charge of all of the medical records, but having different parties doing medical record software, and having doctors being in different practices and in different medical groups and in different accountable care organizations. I mean, everybody adapts to what goes on in the system. And if you tweak something over here, somebody's going to change their behavior over here to maximize their benefit. And so I think what you're talking about is that the medical record companies of the world are adapting to what they see as the opportunities out there and building their gardens for their own advantage, because nobody is in charge. And we may think that the government ought to be in charge, but there is definite controversy around that. So did somebody else want to weigh in on the health information exchange question, or the idea about seeing a patient that you wish you had more information about? And I think we wanted to ask Anthony about that.
Yeah, let me just say quickly, and I'll pass on the mic. I don't think anyone would argue with the idea that if you had more information when a patient shows up, that's better. Anywhere in the system, certainly starting with the ambulance all the way through the ER and into the hospital and into the outpatient offices. But the problem with HIEs is who's going to pay? And the current state of HIEs is kind of dismal. The ones that have been successful are private, so they're within networks of hospitals.
New York is a really big one.
You know, a lot of major cities have them within individual and private networks. But the public HIEs across the board have failed miserably because of that basic problem. If I'm going to share in the system, I'm not going to pay if someone else benefits, and likewise, equal and opposite. But the problem is that if we're going to go into this new world with ACOs and global care and value-based payments, you kind of have to have an HIE, right? You've got to measure the care of the patient all the way through the process to know if we're succeeding or not, and if we're not succeeding, where are we failing? So it's kind of a circuitous argument because you can't get there without basics. But talking to Ram's point, the failure is really a central failure. If we can't, as a nation or a state or a county, decide on services like police services are good for all. Sanitation services are good for everyone. Everyone pays taxes for those sorts of things. Everyone expects to pick up a dial tone, but we can't figure out how to put in HIEs, then something's wrong.
Good point. So real quick, you brought up a good point, about the vet having to go back after 3 days. In San Francisco, we have our chronic patients that, I don't know, maybe I pick them up twice a day, and maybe all our other ambulance companies picking up. We have some hospitals. We bring the patient in. They say, "Well, you just left 2 hours ago." Then we take them out. They go walk away. They fall down, and they are back in the hospital. So we have a lot of these patients are in and out of the hospital 3, 4, 5, 6 times. Then they start making the circuit through all the hospitals. I don't want to go back to that one. Take me to the next one. Take them to the next one. So all these patients are on first name basis when you walk in the door. And it's not like, "Hey, how you doing?" "Oh, crap, this guy's back again." Or, "How can we get him out first?" or whatever. So, having the ability to pre-alert the hospital that we're coming in with, with the patient is a good thing. The other thing I was thinking about too, as far as data sharing and everything, I do an electronic PCR, and when I'm done, I transmit it to, somewhere. I have no idea where it goes, but I have to print out a paper copy, which the hospital gets. And sometimes, it takes 20 minutes to 40 minutes to an hour if we have a really involved call to do everything gets put on the paper. But if the city and county of San Francisco is at a low level, they don't have any ambulances available, I have to shut the computer off. Doesn't matter where I am in my PCR, fold it up and throw it in the ambulance and go. Now I might not get back to that PCR for 7, 8, 9, I work a 24-hour shift. So, in San Francisco we're mandated that we have to give them a copy of the PCR either by hand or we can fax it within 24 hours of the call. So having a way to get it to where it needs to go with all the data sharing and everything, I think is really important. I don't know if that's what you wanted me to talk about, but
Your experience.
yeah.
I think it's the same thing.
Why don't we, Dave, you got something to add before we open up to the...
Just a quick point, because maybe it's because I'm a Democrat, but I like government. I think one question that I don't know, maybe it's like I said, maybe it's the Democrat side of my brain, maybe it's the MBA side of my brain, but we talk in many cases about voting with one's pocketbook. And we have this conversation with respect to other players in our industry as well. But Ram, I think you make a really interesting point about the pain of certain companies that are out there, what they put out, and there are well-known complaints in our industry. For example, there is one company that is a web-based system that, again, it's a web-based system that works in a place where there are lots of tornadoes. Every time network goes down, because there's a tornado come through, system stops working. Yet people keep buying it. And same thing, certainly with Epic, people keep buying it. They're buying bigger, let alone buying it. It's getting more and more complicated. And so I wonder, and maybe this is, if I may steal a question to the panel, because you guys are far more expert in this than I am, but so we encountered in our space where pain points are well known, yet the same incumbents continue to win. If I had a dime for every time somebody complained about Epic, I wouldn't need any funding. And I think, but yet Epic gets bigger, and it's continuing. I mean, we're based out in the East Bay, where John Muir, for example, is putting in, if I'm not mistaken, a very large Epic installation now, and that's one of the most sophisticated hospitals in the area. Why?
I mean, a lot of this has to do with the culture of decision-making administrations, and I've been involved with 2 RFPs and Epic builds, and I deal with large payers on sort of consulting things that I've done in the past for the last 5, 6 years, just on the computing side. It's the institutional culture of healthcare organizations, whether they're payers or they're delivering the care. They're very risk-averse organizations. There's no impetus for innovation because their income stream is largely guaranteed. And I think, actually, this is on camera, I'm going to still go out on the limb and say that the vast majority of executives in healthcare organizations are not the cream of the crop. They're not innovators. They're not people who are willing to take any sort of risk and put themselves on a limb. They're climbers. Wow. So, I mean, it's out there now. But anyway, the point of the matter is that I do think this is true. I think a lot of people who have been in healthcare administration would support my claim. What do you think?
But we're up. The thing is, we're up here.
If it softens the blow any, I think that much could be said in many industries about being risk averse or timid about being innovative. I used to work in the environmental industry, and it was hard to get people to adopt new practices. And then there's the old saying, maybe dating myself here, but there was the old saying in IT that nobody ever got fired for choosing IBM, when they were the big monolithic supplier of hardware. And so it was very hard to dislodge them as an incumbent. So you've seen that pattern in other industries as well.
But you've also got, if I may, you've also got panels here. You've got panels. Sorry, thank you. Just in the Bay Area alone, these are spreading very quickly. From New York, I just found out that Health 2.0 just opened a chapter in Pittsburgh. There is a cacophony of complaints happening, and you've got people. It's becoming, by the way, cheaper than ever, like free. With a toss to my friends over at Dr. Chrono, that you can get an electronic health record for nothing. That gets rolled out within a hospital for pretty quickly. What is it about the incumbent systems when they are not incumbent, but they're being put in for the first time? I think that's the thing. If you're getting updates on an existing system, I get it. Then you've got to redo your data sets, and there's all sorts of pain there. But I'm thinking about when people go for the first time, why go to the one that everybody, sorry it's on video, why go to one that everybody says sucks? When you can go to one that people either don't know, but could be innovative, or one that people seem to like. And we dealt with this actually, it was really interesting in applying for an RFP recently. We're a small company, and literally said to this particular agency, we are a small company, and we have not been around for 20 years, we've been around for 4. And they said, which was an amazing thing, this was about 3 weeks ago, everybody starts somewhere. And if you can let us touch it, and let us find value, and let us play, which seems to be the culture of innovation, then we don't really care if you've been around. It was a remarkable, this was my government agency.
It's remarkable because it's the exception. I think people are cautious. I know in some of the large organizations I worked in, it was considered very risky business to go with a small provider. There are lots of stories in lots of industries of this problem where if you're a small provider, there's sort of a cultural mismatch or misfit with large organization culture. And large organizations are terribly afraid that you either won't be able to meet their demand or that you'll go out of business. And in some cases, it's sort of a legitimate concern because maybe they've been burned. So going with an Epic is sort of, they're a tried and tested and proven.
And hated.
But they're a known quantity, okay? So people will often stay with the known, problem rather than venturing out into the unknown. And I think we're seeing a certain amount of that. And hopefully, maybe we're shielded from it being in Silicon Valley. Our culture is to try new things and, fail early and fast and so forth. But I'm not so sure that's as common around the rest of the country. So we really haven't given you a chance to ask very many questions.
Well, one last comment.
I want to get to the audience though.
Oh, okay. Just quickly, I think they all suck, and I think that it doesn't matter because Ross Point's actually really well taken. They've been around for 34 years. We're not the people that they're selling to, so they don't have to be usable, and yet they keep selling and they keep growing. And then if you tap into the needs of the very risk-averse administrative structures, they'll keep going with one system until it becomes so big that the government will say, oh, wait a minute, we didn't give you direction, and now there's one system that's grown out, that's taken over the whole industry. We can't have that in America, so we need to now break you up. It's just foolish. I don't like government all that much, so.
Let's try a question right here.
Question around the standards. I mean, why is it government's responsibility to bring
That was my
standards
point.
in? Because in many other industries, like say semiconductors or whatever, companies come together and they form standards because it's good for the industry overall. So why can't that happen?
Simple answer. Who's the single largest financier of healthcare in this country?
Insurance?
Who picks up the costs, the majority of the costs for you when you're 75 or 80 years old in this country? It ain't Cigna. You know, that's the point. So they live their life through individual payers if they're productive members of society, and if they're not, they're on the government from a very young age, and Jonathan's government. And if they continue, I'm a libertarian, so I'm good. If they continue along that path, right, and now when they hit their 70s and their 60s and they had their pack a day, they're on the government troll, right? So the fact of the matter is that it's in their interest because it's in our interest because guess who's funding the government, right? I pay taxes.
Who's allowed?
Right here?
Lest I get thrown into a hole, let me just clarify. My only point of making the government comment was that as far as picking someone to blame, but as far as picking someone to blame, I think it's government because they're the largest payer, they're the largest buyer, they're the largest everything. They're also a really easy target. And one of the things we talk about a lot in EMS and we talk about in healthcare in general is systemic flaws. And I think the problem is when having worked at OMB, you know, I mean, it's a behemoth. I mean, it's beyond a cruise ship to try to turn this thing, and it's a really easy to make innovation flaccid, to try to blame government and basically say, well, if government doesn't get on board, nothing's ever going to happen. Therefore, we're just going to wait until it happens, and nothing gets done. And I think if the target is so big, as opposed to saying maybe there's something manageable. I think you made the point, actually, ironically, in that same vein, which is let not the perfect be the enemy of the good. And I think if rather than saying government needs to change, which can take a very long time, it doesn't have to, but it does. It does in practical terms. That maybe there's something shy of changing government or requiring mandates to get things done. That was my only point. Saying I don't like to poke at such a large problem because it'll never get fixed if that way it's intimidating, as opposed to finding something we can chip away at.
Let me clarify my comment. If you're going to put out standards for quality of care, if you're going to intervene in the process of innovation, in the delivery of care, intervene where it matters.
Sure.
Okay?
I agree with that.
My point about big data should become crystal clear right now. There's no paucity of data out there.
Good word.
There's millions, tens of millions, hundreds of millions of clinical encounters every year, right? There's no paucity of data. It's not collected in a computable fashion. Go ask Epic. Anyone's used Epic? We've talked about this recently, because I still deal with some billing stuff for Sutter. Go extract a date out of Epic. It's hilarious. It conforms to no standard you've ever seen in your life. And it's a date string. It's a simple date string. And even that is proprietary.
All right, so let's get some questions from the audience here.
I think we have one. This gentleman? Go ahead.
Sure. So I've about a million things we could touch on, but I'll say it on one. So the tectonic shift is the ACO, right? And and people don't realize it's coming, but it's coming fast. And it's the Cobra effect, right? If you don't know those, look it up. But the large health organizations are going to buy all the pieces of ACOs, so they don't have to split the check at $840 per person, right? So you see Cedars-Sinai buying 3,000 physician practices last year. You see, and the mid-tier hospitals are going to be gobbled by the large hospitals. And and we just saw United Health Group buy the largest travel and care nurse organization at $1 billion, right? Because they're going to send people out to babysit the ultra sick so they don't show up in the emergency room, so they get dinged on readmits. So the point of attack, though, within ACOs is emergency care, right? They do not want people coming to the emergency room. They do not want people at readmits. They don't want ambulance drivers being picked up 4 or 5 times. So, the challenge is going to be we're only going to have 5 EMRs, right? Maybe. You're going to have Epic, and they already have 1/3 of the population, so they're probably going to have half. And you're going to have Cerner, you're going to have McKesson. And so you're going to have to play with them if you're going to do that integration. But how do you see this attack happening on the emergency room as kind of the, we just don't want people going in those doors. Right? Everything else we don't care about necessarily, as long as you don't come through those doors more than once in a 30-day period.
The trend is towards not admitting, not seeing patients, right? So the continuum is the doors now at the admission process, not in the ER. So the care of emergency medicine is actually transitioning to up to 24 hours of care, where the full admission occurs. So you see ERs adding observation units, being staffed by ER physicians for 15 hours is kind of the maximum of the industry now, for certain conditions. And then that kind of gets passed on to the hospitalists in this kind of now gray zone prior to admission. So the ER, obviously, they don't want to have patients that don't belong there go to the ER, right? There's better locations of care, and all of us on this panel would agree. And please have those people go to their doctors for their sore throat. We'll take care of the sick people. That won't change, but it's going to move upstream to the door to admission for the ER.
We're seeing something actually very different. Sure, we're seeing something very different, which is EMS agencies, especially those affiliated with hospitals, which is one of, by the way, for everyone who doesn't know, it's one of 4 types of EMS that essentially operate across the country. But particularly those, but not only those, also lots of private agencies, including several in the Bay Area, who are looking to do post-hospital follow-up as an active part of their business. And particularly with respect to ACOs and the shared savings model, the EMS agency is actually incentivized to do that post-follow-up care. So it's actually cheaper to send a medic out, for example, in fact, one of our clients is part of an ACO, and they're the ambulance company, that's our client. The ACO involves the hospital and its resources, and so they're one piece of it. Within 30 days of discharge, particularly on those higher level instances, but because if you bring back a patient who had a bum foot, your penalty's not all that big anyway. But if you have that person do a proactive follow-up within 30 days, on the one hand, you're doing better care. If you need to bring that patient back, but you're doing it proactively, it's not a readmit, because that person is being brought back as part of more accountable care. So it actually works out nicely. If they are using technology, which is again where we've sort of come into this game, you can be out there in the field and do, for example, a teleconsult, and using telehealth, using photo and video and location information, essentially using a system like ours as a pre-hospital HIE, if you will, that you can know who this patient is, what meds they're supposed to be on. Hey, Mr. Smith, how you feeling? Are you taking blankety blank that you were supposed to take every couple days? Well, no, I'm not. I'm feeling kind of crappy. Or I'm just tired. I don't need to go to the hospital. You can have that exchange right there and engage the other pieces of the ACO. That's happening now. And so EMS agencies have gotten wise to that. One example that comes to mind is where they actually describe their relationship with the ACO as earning a portion of the monies made on that proactive follow-up, and the differential between that money made and what the readmission cost would be. So it's actually a really interesting financial incentive for them to go out and do that proactive follow-up and keep that person from coming back.
That's encouraging.
Yeah, well, like I said, that's happening now. The other side of it, which actually, speaking of AMR being in the room, is EMS agencies are going out and also trying to do what you're describing, which is pull other pieces of the ecosystem together, whether that means buying a home health agency, for example, and engaging EMS and home health for post-discharge. Again, we describe ourselves as a technology for pre- and post-hospital care. Not in hospital, we leave that to smarter people on the panel, but pre- and post-hospital care, and then because it's the same providers, going back out again and then empowering them to come back, when they need to take that patient back, having the information they need. It is very exciting that it's all happening, but a lot of it's happening under the radar.
I think there's a question over here. Has that been answered?
No, it's not answered. I can
my reason behind coming here was I was looking at school integration as well. So I kind of draw parallels between the two systems. Schools are facing the same problem, same vendors, unable to update software, those kind of things. And they're building similar like the health exchange, which is SLC, to bring all the schools on board, and then you have providers get back into the school. I shouldn't call providers, but people who want to like push education content, do roster management and all. And that is still 20 years old. I mean, it's so hard. I mean, there is no HIPAA compliant, nothing. Again, there is set of building blocks which are like very high. The barrier to entry is so high that everyone who's involved in it is now again a partner in that trying to sell. So the way I got interested was, in my daughter's school, they still say the president is Bush. And when I asked why, they said the vendor, to update the software, it costs a lot to update the software. And believe me, there's a lot of money being exchanged over there.
What's that?
I don't mind going on camera, and I can see this like probably 100x in the healthcare, and that's harder to fix. This is even much harder. So,
There's one in the back. We've got one more question. I think there's one in the back.
Yeah, my question is, it seems like physicians have a lot of pain that they're facing, both in productivity losses in actual workflows, but as well like in systemic problems. Are there tools that physicians are paying for themselves, or maybe even adopting for free with like freemium models, these types of things, to get an advantage, much like people in the enterprise did 6 or 7 years ago by adopting Box or Evernote or different tools? Are you guys seeing things your colleagues or yourselves are using to get an advantage to be more productive?
So you're talking about tools to increase productivity to try to combat some of these things?
Exactly.
Yeah, so I mean, right now, one of the biggest things, and I commented on it, was scribes. It's a physical person, typically a pre-med, who you hire at 10 to 12 bucks an hour to follow you around and take notes for you. So you don't have to actually deal with the EHR. That's our current technology.
It's Evernote.
And yeah, it's basically Evernote. So what I'm trying to develop with Josh and my team is a system that does that electronically. So you don't have to actually we can then move from a physical person to an actual system that allows you to then offload that and actually dynamically document and not have it slow you down. And I think that the productivity aspect, we're also adopting physician extenders. And we have physician assistants and nurse practitioners that help us in all the different aspects of our field to try to do things that are lower acuity or kind of follow up so that we can then combat the financial constrictions that we're feeling. But I mean, a lot of that is coming, and it's just the system now that we have is very expensive. And there's ways that we could, there are tools that we're using, but in some ways, we have to remember what we're fundamentally trying to do in terms of what we're taking care of the patients. And then what we get paid for is what we're going to get paid for. And then, the government's going to set that bar, basically.
I mean, Nuance has made a killing in all this, right?
Nuance is the speech to text company.
Not this week.
Yeah, so just front-end voice recognition, voice to text, and then there's also lots of companies that have grown around using low-cost offshore correction of that first voice-to-text translation and then doing medical transcription essentially on a template, meaning the initial transcription from voice to text and correcting it. So there are lots of people who are kind of middleware and providers in that.
All right, I think we should start to wrap it up here. I want to thank everybody for coming. I want to remind you to keep looking at the SVForum website and Meetup group website for our next meeting in March, which we're working on and which very likely will be on the topic, another aspect of electronic medical records. And then invite you to make sure you're on the mailing list for updates. And if you have some time to send us a suggestion of a topic you'd like to hear about, or something somebody would be a good speaker, we'd love to hear about it. So thank you for coming, and thank you to our speakers.